Thank you very much for the introduction, and thank you for the opportunity to come and speak and join in this fabulous conference. And good afternoon, everybody. Good morning, everybody. Following on from my talk yesterday, which was largely around trying to encourage organisations to work more with nursing and develop nurse-led services. And if we're looking to build capacity for kidney disease, we certainly need to have more collaborative and multidisciplinary working within Abu Dhabi. I started working there in 2012. At that time, the true incidence and prevalence of end-stage kidney disease and CKD were not known, and it's only really through the work that's been done over the past 8 years that that has been defined. The take-on rate to dialysis now is around 130 to 150 new patients per million population per annum. The prevalence is around 400 per million on dialysis, and the growth rate is around 6 to 8% per annum. That's compared with about 3% in Western Europe and the USA. The dialysis population there is predicted to double in the next 5 to 7 years. 95% of the patients back in 2012 were presenting to dialysis as an emergency, and that was compared with 30% in Western Europe. We all know, we've heard many presentations over the course of the conference, that in terms of vascular access, that catheters incur higher cost, higher mortality, very poor rehabilitation, and no chance for prevention or intervention. And at that time as well, only 2% of the patients in Abu Dhabi had an AV fistula at first dialysis. If we look at the benchmarks for dialysis prevalence in OECD, ignore the red lines because that's not Abu Dhabi, which is what I'm hoping to show you, which is actually here. So you can see within that in 2009, Abu Dhabi was around 30 per 100,000, and in 2013, further down here, find it, is around 36 per 100,000. The bottom line is what's really important, and this line is for the Emirati population. So the Emirati population within Abu Dhabi is only around 15%, and you can see here that we're looking at rates of 100,000. If we compare vascular access international patterns going back into 2012 when this first started, you can see here that within Europe and Japan, very high levels of fistulas within their patient populations. The USA had permanent access, but a high number of AV grafts. And here in Abu Dhabi, you can see here, we had less than 50% of fistulae and a very high number of catheters. Another comparison just to show you, so again here, Abu Dhabi coming in here at this level, 50%, compared with, say, a country like Serbia, where they're running around 90 or 95%. If you look at admission rates, inpatient days and mortality in terms of comparing fistulas and catheters, this is some UK data. And you can see on this that admissions due to access, if you have a catheter, it's around 2.5 times your likelihood to have an admission due to access. You're 10 times more likely if you have a catheter to be admitted due to sepsis. You'll have 2.5 times the amount of days in hospital due to access, and 13 times the number of days due to sepsis if you have a catheter. And the mortality risk is around double. Within Abu Dhabi, it was calculated that the minimum excess cost of having permanent lines resulted in around $7 million a year. Looking at the prevalence of CKD in Abu Dhabi, if you have a look across all stages of CKD, 2 to 5, in the 3 to 5 group, you can see that within the national population, it's around 4.5%, population. But the interesting line to look at here is in CKD2, where you can see that within the national population, the Emirati population, terms of CKD2 is running around 20% for nationals and a similar number for expatriates. So this is basically a tsunami of CKD on the horizon. It's even more important because if you look at the age of the population of Abu Dhabi, 85% of the population are under 40 years old. So, and a similar situation in the expatriates. So the CKD is going to increase. And then if you look at Abu Dhabi age and CKD prevalence as a percentage, and this is compared with UK data, and you can see also that in every single age group it is higher within Abu Dhabi. So our solutions proposed to try and address some of these issues. The first one was around an early detection program for CKD, and that commenced in 2014 and started off with a partnership between secondary and primary care. And within the primary care clinics, automated EGFR reporting was implemented and allowing automated detection of CKD. We implemented an algorithm-based management system and an online physician support system. And then we put community nurses out into the primary care clinics, acting as navigators and educators. So these nurses were absolutely essential to identify patients with or at risk of CKD. And alongside that, multidisciplinary teams were set up and pre-dialysis clinics were set up in the clinics. Something's not happening here. Well, there we go. In terms of the vascular access service, historically that was a bit of a disaster with no real unifying service. So we developed the vascular access service in 2013 and appointed a vascular access nurse specialist to lead this project. We implemented a nurse-led clinical pathway with nurse referral to the clinics, and this was quite a big change within Abu Dhabi because nurses were at that time not able to make direct referrals of their own. Referrals could only be made by nephrologists. So to change this was quite a big challenge, but it was considered that the nurses were completely the experts in being able to identify complications with patients and fistulas. We set up nurse-led vascular surgical clinics in every unit and introduced a routine monthly surveillance program which was run by the nurses using transonic. The nurses also undertook catheter removal actually in the dialysis clinics, which had not been done before. So that had meant patients going off to the hospital to have those removed. And so now we were removing them in the OPD. It was also important because previously, even if patients had a fistula created, quite often it wasn't unusual to see patients months later still with a catheter in situ. So this was a big clinical improvement. And the focus of this was on both prevalent and incident patients. So this is what the adopted model looked like. So we've got, again, see the timely access creation, following the clinical pathway. I'll show you that in a second. The pre-dialysis multidisciplinary team clinics, access clinics and nurses in each of those clinics, trying to push on fistula first, a surveillance program, and the direct nurse referral. This is the pathway that was used, and obviously it's a bit too busy for you to go into every part of it, but just to show the entry points of that into our vascular access nurse service. So this is our nurse, and she can have referrals coming in from pre-dialysis, from primary care, from inpatient units, or any other unplanned emergency. And all of those go through her, and she will be the one who will coordinate getting the patient safely through to the right access. The impact has been quite incredible, and you can see here, so back in 2012, and you can see that here we've gone from under 400 fistulae up here to over 800, bearing in mind the patient program has increased from patients in 2012, around 450 patients, to around 1,200 patients today. This is the number of lines in the red line, and the green line is our number of catheter infections. So you can see an overall improvement in all three of those parameters. Our vascular outpatient activity changed considerably. So here back in 2012, going from around 400 procedures up in 2016 to around 1,800 procedures. And also vascular access procedures here in 2013 from 100 up to 300 in 2016. Our fistula at first dialysis also improved significantly. So you'll remember I said to you down here, less than 2% back in 2012 when we first started the program, and in 2018 we were around 25%. So a significant improvement in fistula first. We know within the USA that a patient starting dialysis with a line incurs around a $30,000 additional cost in the first year. So for us in Abu Dhabi, between 2015 and 2018, this equates to a $9 million cost saving, which I think is significant. I spoke a little bit yesterday about our Masters in Renal Nursing program that our nurses are encouraged to go through to improve their expertise to be able to lead the development of services. And this was a small study, observational study done by one of our students last year, looking and following up patients in terms of fistula first in Abu Dhabi. In 2015 followed up for 1 year. So if you have a look at this, you can see that in the fistula first group and the non-fistula first group, there was not much difference in terms of males, around 65%. In the fistula first group, around Emirati is about 18% in the fistula first group, and about 32% in the non-fistula first group. In terms of follow-up was around the same, around 340 days. Loss to follow-up was higher in the non-fistula first group at 26% compared with 10%. There were more diabetics in the fistula first group, 71% compared to 57%, and the mean age was higher in the fistula first group. If we look at the outcomes here, you can see that for the admission all causes, there was a higher number of admissions in the non-fistula first group, 78% compared with 51%. There were more access-related admissions in the non-fistula first group, 61% compared with 24%. There were more admissions due to sepsis in the non-fistula first group, 29%, 30%, compared with 8%. And there were more interventional radiology interventions in the non-fistula first group, 34% to 8%. We had 1 death in the fistula first group and 15 deaths in the non-fistula first group. And this was all in the first year. So going back to the vascular access patterns, and if we looked at 2012 and include now 2018, you can see here we've still got Europe and Japan with high numbers of AV fistulae in their programs. The USA has gone from 2012 having and now moved to 2018 having more AV fistulae and less AV grafts. And here in Abu Dhabi you can see here we've gone from having more AV fistulae and less catheters. So, in conclusion, within this part of the world, the prevalence of CKD 2 to 5 is very high considering the age of the population. End-stage kidney disease prevalence is low compared to international comparisons. The incident rates for dialysis are high, and the growth rate of the dialysis population is also high. The dialysis population is predicted to double in the next 5 to 7 years. Early detection of CKD has reduced late presentation from 90% to 30%, and fistula first has increased from 2% to greater than 25%. We can see that fistula first clearly improves patient outcomes. 80% of our prevalent patients now have an AVF/AVG which approximates to international norms, and quality outcomes have improved at reduced cost, and this is an example of value-based healthcare. And the demand for this service will continue to rise. In conclusion, service development and improvement is essential to build capacity, but to do that, a multidisciplinary approach is essential. It's really important to include all locations where renal patients are seen. That's not just in your dialysis clinics, and this is where nurses can have a huge contribution to make within the care of patients and in terms of making sure that they can go out and work remotely in other areas. Nurses deliver the care. They are the experts and should be included. Nephrologists must recognise and champion the development of nurse-led services if we want to build capacity. And nurses must be involved in all aspects of the process, from policy, quality standards, care delivery and evaluation, through data collection and audit. So I would like to ask you, do your nurses have a seat at the table of decision making in terms of service developments within your organisations? Thank you very much.